Okay, so here we go. Immune system drugs. So most of these drugs are going to be anti-infective drugs, but it also includes immunosuppressant drugs as well as chemotherapy drugs. So we're going to start out with the antibiotics. So basically we have different classifications of antibiotics. The main groups of antibiotics include penicillins, cephalosporins, tetracycline, aminoglycoside, macrolides, and sulfonamides. And then we have smaller groups or miscellaneous, including glycopeptides, lincosamides, and zoledronidinones. We're not going to really worry about knowing the class on the miscellaneous classifications, but you do need to know the major classifications of antibiotics. Now, when we talk about antibiotics, basically we group them in two different ways. We group them by drugs that kill bacteria. Those are called bactericidal, and drugs that just prevent bacteria from reproducing so the body can kill off the bacteria. Those are called bacteriostatic. Static or stasis means to stay, and cidal means to kill. They work by different mechanisms. This is just kind of explain a little. You're not really going to be tested on what's a beta-lactam. Well, you'll recognize beta-lactams, but what do they do and all that. So these kill, and how do they kill? So the cell wall inhibitors. Bacteria have a cell wall. It's like a plant in a sense. Humans don't have cell walls. We have cell membranes. So the cell wall keeps all of the inside stuff inside. If you break down the ability to keep that cell wall, all the stuff falls out. That kills the bacteria. So that's what a cell wall inhibitor would do, and that's how it kills. Now, the beta-lactams, it has to do with a chemical that's located on the cell wall of the bacteria. And there's a lot of different beta-lactam drugs. Now, because there's a group of them, there is cross-sensitivity. Because if the patient has an allergy to a component of that beta-lactam, they could have a sensitivity or an allergy to other drugs that have that same piece. It doesn't automatically mean that if somebody's allergic to penicillin, they're going to be allergic to cephalosporins or a carbapenem or a monobactam. But there's a possibility. So penicillins are the oldest in this group. They actually are made from mold, penicillin mold. Cephalosporin is another group. Spores, mold. Mold reproduces by spores. They are related. Carbapenems and monopenems or monobactams are kind of newer ones. They're smaller groups. They're more potent. We use those for more serious infections. Penicillin, one of the very first antibiotics that were created it was discovered in 1929 and came to market somewhere in the 1930s, which is right around the time of World War II. Sulfonamides were the only other antibiotic, which, depending on who is the author of whatever, some people group sulfonamides as antibiotics, some just list them as anti-infectives, not as true antibiotics. They're antibiotics to me. I think you'll find more that say it is than not. Those were the first ones. Those were the ones that were out there first, but penicillins were the most widely distributed. Now, prior to penicillin, when we talk about war, most of the fatalities in war did not occur from dying in battle. They died from infection. They got cut. They got a gunshot wound. Whatever the case may be, they survived the battle, but then they got an infection from their injury, and then they died. So penicillins helped increase our lifespan because for the first time we could treat that infection that was killing everybody. The problem is, back in the 1930s, early 40s, oh my gosh, you got a sore throat. Here, take a penicillin. Oh my gosh, you got a runny nose. Here, take penicillin. We became resistant because we were using it for viral infections. We don't know as much as we do today when it comes to bacteria and viruses and how to treat them and all that kind of stuff. What happens is bacteria and viruses too, and fungus even, they're smart. They have been on this earth probably longer than man. They have adapted to their environment. So if we don't use these anti-infective drugs properly, which means finish them all as prescribed, anything that's left behind can send a message as it can change its DNA. It can change its genetics. And it says, ooh, I know your defense now. I'm going to genetically modify myself to be stronger than your defenses. And then the next time we treat it with that antibiotic, it says, no go. And we get super bugs. And we have resistant medications. And we have infections. And they're foreseeing that in the next 70 years, common infections are going to become deadly again because we can't treat them anymore. Because the bugs are smarter than our drugs. And it will continue to be that way if we don't fix it. So one of the things as a technician, we want to make sure that there's information that the patient gets that says complete all of this medicine. Usually you're sick before you know you're sick. Your body's defenses go into action before you really feel the onset of the symptom. It's when you feel the onset of the symptoms that you start feeling icky and you decide you're going to go to the doctor. Then we take our antibiotics. Well, some antibiotics have side effects, especially penicillin and cephalosporins. They give you diarrhea. Antibiotics are going to kill off good bacteria with bad bacteria, change the way your body is. It can throw off and cause yeast infection because you killed off all the bacteria that used to keep all the yeast in check, and now there's nothing there, so that goes crazy, and you end up with a yeast infection. So it's all about normal body flora maintaining itself, and when we disrupt that, it can throw things out of whack. So when you start taking the medicine, you start feeling better. So people don't like the side effects, so when they start feeling better, they stop taking it. But if you don't take it for the full course of therapy, there's still some left behind. There's just not enough of them to make you feel sick. But once you stop taking the antibiotics, they start gearing up again, and they start reproducing and get bigger in numbers, and then you start feeling sick again. And a lot of times people will restart the antibiotic that they stopped, but now the bug is resistant to it. And it creates a bigger infection. So those are some things when we're handling or thinking about antibiotics. Now, protein synthesis inhibitors, those also kill the bacteria. Think about if you weren't allowed to have any protein. What's protein important for in your body? Builds muscle, right? So bacteria needs protein too. It can't survive without it. Protein is one of the 3 major components in our diet. If you are completely without protein in one form or another, you won't survive. Same thing for bacteria. Folic acid has to do with the way that cells form and are healthy. So those also can be bactericidal. Now, the penicillins, we can abbreviate PCN, and we identify the generic penicillins by the drug stemacillin. Penicillin is a class, but it's also a drug in the class. It's very widely used. It's used for a lot of things. It's used for ear infections, respiratory infections, strep throat, sexually transmitted infections. I need to change that from STD to STI. We don't use B anymore. They're not diseases, they're infections. A few of them can become diseases, and commonly for dental. If you have an abscess or an oral infection, or if you have problems with your heart, before you go to the dentist, you take it prophylactically. Unless you're allergic to it. You don't want to take it if you're allergic to it. Anaphylaxis is very common with penicillins for people who have allergies. So that hypersensitivity is a concern. Main side effect, diarrhea. Now, what we can tell the patients, eat yogurt, drink buttermilk, take some kind of lactobacillus kind of, probiotic or something. Replace the good bacteria that you've gotten rid of with the antibiotic to keep everything working how it should. Most of your penicillins are going to be taken on an empty stomach because they get broken down with stomach acid. There are some exceptions. The ones that are really more specific to take on an empty stomach are the penicillinase-resistant penicillins. So one of the things that bacteria can do in response to penicillin is they created this chemical, penicillinase. Well, it's an enzyme, and it breaks down penicillin. So we had to create penicillinase-resistant penicillins. So they can't get broken down by this chemical. But you got to take it on an empty stomach so that you get the full effect of it. The other way we can kind of counterbalance that effect is use a combination drug. So the combination, one drug will kind of go in and block the penicillinase so the other drug can do its job. A lot of sounded like lookalikes. Ampicillin and amoxicillin specifically, how we can tell the difference if you're reading a bad handwriting, how is it dosed? Amoxicillin's 3 times a day and ampicillin's 4 times a day. And like I said, there is a cross-sensitivity with cephalosporin. That's an ear infection, middle ear infection. So we've got amoxicillin, which is brand name Amoxil. It comes as an oral suspension in different concentrations. And once it's reconstituted, so it comes in a powder form, we add the water. We don't add the water until the patient comes for pickup. We want to make sure it has auxiliary labels, refrigerate, shake well, and it expires in 14 days. So we want the patient, if there's any left over after 14 days, they need to throw it away. It comes in capsules. It comes 250 milligrams and 500 milligrams. And I'm not going to go back to the other slide. And then it also comes in a tablet in 500 milligrams and 875 milligrams. And that's what it looks like. It comes in like a bubblegum flavor, which to me was always nasty, but never tasted like any bubblegum I ever had. So amoxicillin clavulinate. Sometimes it's also written as amoxicillin clavulanic acid. Clavulinate will help protect the amoxicillin so it can do its job. So this is one of those combinations that's pretty good for penicillinase resistance. Augmentin, it's augmented penicillin, or ampicillin, amoxicillin. Cillin. It's augmented amoxicillin. So augment means to boost up, to enhance kind of thing. So augmentin comes in tablets, combination strengths. So usually when you see it's always got 125 milligrams of clavulinate. So it may just say augmentin 250, augmentin 500, or augmentin 875. Comes in chewable form, which is kind of good because anybody here ever take an augmentin tablet? It's kind of a horse pill. They're pretty big. They're pretty big. So chewable, that's beneficial. And then it comes as an oral suspension and as a powder for reconstitution. And it comes in different flavors. And some of the generics are like pina colada flavor, so there's some different flavors there. Now these do have a little bit different in the clavulinate part, but again, the doctor's going to write it based on the amoxicillin component. So they'll put 125 per 5 ml. They're not going to write the whole thing out usually. These have to be discarded after 10 days and still need to be kept in the refrigerator. And, of course, because they're suspension, shake well. It also comes as an augmented extended extra strength. Now, like I said, penicillin comes penicillin, and penicillin, there's a lot of different ones. There's penicillin G, there's penicillin VK, V potassium. This is the one in the top 250. Comes tablets, 250 milligrams and 500. Unfortunately, I didn't get to pretty up all the slides. I got content, but maybe not pretty pictures. Then we go on to the cephalosporins. So cephalosporins have the drug stem of Ceph, CEF, or CEPH. They sound the same. So identifiable. The challenge is there's lots of sound-alike lookalikes in the cephalosporins, and your list is minimal compared to what's really out there. So it's a lot of the same uses as penicillin. Oral infection, take it prophylactically with surgery. Sometimes we give a dose before surgery and a dose after surgery. Respiratory, sinus infections, urinary tract infections, intra-abdominal infections. Similar side effects to penicillin, with diarrhea being one of the major ones. Of course, again, that cross-sensitivity. When we get a prescription into a pharmacy for cephalosporins and it flags that the patient is allergic to penicillin, there's a couple of things. We can check their profile, bless you, and see if they've taken cephalosporins before. If they have, then they probably don't have a cross-sensitivity. If not, the pharmacist is going to talk to them and say, hey, because you're allergic to penicillin, watch out for any kind of sign that you also are having a reaction to this medicine. Cephalosporins come in generations. There's 4 generations. Generally, as we go from generation to generation, the newer ones, the 2, 3, 4, each generation up tends to be for a more serious type infection. And most of them, as we get into the 3s and 4s, are injection only. There's, I think, one exception. Like I said, a lot of sound-alike look-alike, cross-sensitivity. Now, the oral liquid Cefdinier has a high sugar content. So somebody with diabetes, that may not be a good medication for them. That's known as Omnicef. It also, the 2 of the cephalosporins, when they're oral reconstitutions, can be stored at room temperature. So most of your oral reconstitutions are stored in the refrigerator. So it's easier to just identify the ones that can go room temp and know everything else is refrigerated. So Cefdinier is Omnicef. It comes capsules. I'm looking right at it, can't read. 300 milligrams, and it comes oral suspension, 125 milligrams per 5 ml, or 250 milligrams per 5 ml. It's strawberry flavored. Like I said, it's stable at room temperature for up to 10 days. So we would want to put a label on it, store at room temperature. It's okay to go in the refrigerator. It's not that it can't, but if people want to leave it out. One of the reasons we like some of these liquids to be refrigerated from the patient's perspective, not about the stability of the drug, but if it's cold, it's more palatable. The colder it is, the less you taste it. It kind of makes your tongue cold, so you don't get your taste buds aren't as enlivened. So for some people, the colder it is, the better it is for taste-wise. But this is strawberry flavored. Again, I'm not quite sure how the flavors work on some of these. I've actually never taken Omnicef. I've taken amoxicillin though. Then we have cefepime, which is maxipime. Well, this one's better to match up because you got the pemes. It comes IV powder for reconstitution. So diluent, this is something that we mix an IV with. It has to be sterile. So SWIFI stands for sterile water for injection. Normal saline, dextrose 5% water, bacteriostatic water for injection, or lidocaine. We could give it IM. That's when you would probably use lidocaine. And then it has to be mixed, if it's IV, it has to be mixed into another IV bag, and it's mixed either in normal saline, D5W, or D5 normal. The vials that it comes in for reconstitution are sized 0.5 gram, 500 milligrams, 1 gram, or 2 gram. And that's just kind of what it might look like. And again, that cross-sensitivity with your penicillins. The next one, ceftriaxone, it's rocephin. Yeah, there's not a match up here. I tried to row. I don't know. Again, it's an IV powder for reconstitution. It comes 500 milligram vial or a 1 gram vial, and that's rocephin. It also comes pre-made. A lot of your cephalosporins and some of your penicillins, a number of different types of antibiotics, will come pre-made in frozen form. I call those popsicles. We store them in a -20 freezer, and part of the job is you take them out and you put them on a, oh shoot, the word just left my head. It's not melting. There's another, thank you. A defrosting rack, which kind of looks like, if you look at McDonald's, you know where they store the French fries? And it's kind of like that wavy thing, and it's got a bunch of holes in it so the air circulates. That's kind of what the rack looks like, so the air can circulate, but you've got to keep an eye on it. You don't want to put it out at 8 o'clock in the morning and put it in the refrigerator at 4 o'clock in the afternoon, because chances are it's come to room temperature by then. You want it just to melt. You want it to still be cold when you put it under refrigeration. And it helps with stability. We can take it out and defrost it as we need it, kind of thing. Plus, we don't have to make it. All we have to do is usually slap a label on it, send it up to the floor, bless you, or even just stock it in the Pyxis machine, especially in surgery units. Cefuroxime is Zinacef, bless you. This is also a powder for reconstitution, and it comes in the 0.5 gram, 500 milligram, or the 1 gram size. Whoops, that picture should not be on there. I copied the slide, forgot to take off the picture. And then we have cephalexin, which is Keflex. We dispensed a lot of this at the hospital. 750 milligrams or 1.5 gram. Powder for reconstitution or pre-made. So Cef, similar to penicillin, Cef in the drug stem, Keflex, Cephalex, you got the flex sound in the two of them. So in your choices, you've got a couple that are easy to match, and then you just have to remember the other one. Oops. The next bactericidal antibiotic are the quinolones, also known as the fluoroquinolones. So quinolones are a subgrouping, but it's easier to say, so we just call them quinolones. They're enough in common that we can group them together. These usually are a little bit more potent. We use them for bone and joint infections, respiratory and sinus infections, infectious diarrhea, ophthalmic infections, sexually transmitted infections, and urinary tract infections. Side effects: nausea and vomiting. One to be aware of is joint swelling. So it can cause tendons to swell and can cause joint injuries. So patients who are taking this need to be careful that they don't like step off a curb odd or something like that. They're more prone to that. Dizziness, it can cause an unpleasant taste, and it can cause the patient to be photosensitive, which means that they'll be reactive to sunlight. They can get a rash, a sunburn real easy. So anytime we have photosensitivity, we're going to tell them what? Wear long sleeves, wear hats, use sunscreen. So it comes in different dose forms. Quinolones come oral. Now, you've got to make sure you don't take it with antacids, iron, or zinc. And it's also recommended, because there are some CNS side effects, not to take caffeine at the same time. So don't take your medicine with your coffee, kind of thing. IV is available for more serious infections. And then we have topicals for ophthalmic infections, somebody who has pink eye, bacterial conjunctivitis. These drugs are not recommended for children or in pregnancy. Penicillin, cephalosporins, we give those to kids all the time. We don't give quinolones to kids. They really haven't been studied. And if somebody's got severe renal failure, there needs to be a dosing adjustment so that there isn't toxicity. Your quinolones will end in oxacin. Your fluoroquinolones end in floxacin. We're just going to say floxacin. So ciprofloxacin is Cipro. That one's an easy match. Comes 500 and 1,000 milligrams, both tablets and extended release tablets. Cipro IV is 400 milligrams per 200 milliliter premix, or it comes in a vial, 200 milligrams per 20 ml. And that's a solution. Most often, Cipro is going to be used for UTIs, but it's also used for pneumonia. It's one of the drugs that treats anthrax, which is a serious respiratory infection. Levofloxacin is Levaquin. Oh, levofloxacin, Levaquin, and it's a quinolone. You got part of the generic name and the class in the brand name. Comes tablets, 250, 500, 750, and it also comes as an injection as 25 milligrams per milliliter. And most often this is given as bronchitis. And it can be treated in 1 to 2 doses. So we get a lot of patient compliance, sometimes 4. But once a day for 4 days versus 4 times a day for 10 days or 2 weeks, we get less resistance because people are more apt to complete their course of therapy. Moxifloxacin is Vagamox. That's an ophthalmic. It comes in a 3 milliliter vial. So that's for bacterial pink eye. And then we have Avalox, which is for a systemic infection. It comes as a 400 milligram tablet or an injection in a ready-to-use flex bag, 400 milligrams per 250 milliliters, and the systemic is used for bronchitis. Ofloxacin, the original. Oh my. You're welcome. Is Floxin. It comes as tablets, 200, 300, 400 milligrams, and then it comes as an otic solution. Otic is for what body part? Your ear. So that's for ear infections. 5 and 10 milliliter bottles. Now this next group, the aminoglycosides. So aminoglycosides are pretty potent. They're bactericidal. We reserve these for some serious type infections, including sepsis, as well as MRSA, methicillin-resistant Staph aureus, even they have some pretty severe side effects, however. These drugs are nephrotoxic, which means they affect what organ? Your kidneys. And they are ototoxic, your ears. So they can damage your hearing. With the patient, some dispensing notes. Once a day dosing helps limit the toxicity, gives the body an opportunity to clear the drug out. If the drug is taken in multiple doses throughout the day, they may do, especially in a hospital with IVs and things like that, peaks and troughs. So what that means is about an hour or 2 after they get the medicine, if it's oral, or about 10 minutes, 15 minutes after the IV, they take a blood test and find out how much drug is in the bloodstream. That would be the highest level. That's the peak. And then about a half an hour before the next dose, they do another blood draw, and they see how much is left. That should be the lowest amount. That's the trough. Now, if it's not low enough, if it's not clearing through the kidneys, we want to change the dosing. So it may be that we decrease the dose or we decrease the frequency of the dose. But we don't want them to, if they're not clearing it properly, We don't want it to build up and cause more problems with our kidneys. Gentamicin comes in eye drops, again for conjunctivitis. Well, that's not going to cause the ototoxicity and the nephrotoxicity. It's the systemic ones. And then we have a pediatric formulation. Pediatric formulations are known as PF, for preservative-free. A lot of medications that are given as an IV have a preservative in them. And for kids, that can cause benzyl gasping syndrome. It's the preservative that they use. So when we're giving pediatrics, their little bodies can't break that chemical down. So we need to make sure that pediatric medications are preservative-free. Amikacin is one of the drugs. It's Amikin. It's an injectable drug. It comes 100 milligrams, 500 milligrams, or 1 gram. 500 per 2, 1 gram per 4, same strength. And then gentamicin, garamycin is Genoptic. So that's the one for the pink eye. And then we have gentamicin pediatric, again, preservative-free. So garamycin comes in ophthalmic solution, but it also comes in an ointment. And sometimes they'll use this in babies' eyes when they're born because there could be bacteria in the birth canal, so to protect the baby's eyes. And these are nephrotoxic and ototoxic. So your bactericidals, your penicillin, your cephalosporin, your quinolones, and your aminoglycosides. Now your bacteriostatics. So in this case, we still have folic acid inhibitors, but it's not to the same degree as the ones that's going to kill. So that's why I'm saying, don't really worry about what's the mechanism. What these do is these stop the bacteria from reproducing, and the body can come in and knock out the invader, basically. So these are static. The first group are the tetracyclines. Tetracyclines, also abbreviated TCN for short, but it's got the drug stem of cyclin. Now tetracycline, like penicillin, is a drug and a class. Most common uses for tetracyclines: acne. These can also be used for anthrax, bronchitis, Lyme disease, sexually transmitted infections, sinus infections. Tetracyclines are also effective at urinary or bladder, kidney infections. These drugs cause photosensitivity and nausea and vomiting. Now, the thing about tetracyclines is they will bind up or chelate with dairy or anything that contains calcium. So calcium can be found in laxatives, it can be found in antacids, and of course we know it's in dairy. Generally, where does calcium go in your body? To your bones. So if you take this medicine with something with calcium, it's going to go with the calcium and not work as an antibiotic. But when it goes with the calcium, it can weaken the bone, which is why we don't give it to children. As adults, our bone's pretty much formed. But as a child or in a pregnant woman, the fetus, it could cause weakening of the bones. It could cause problems with the teeth. So we don't give it to kids under 9 till their secondary teeth are being already formed, and we don't give it to pregnant women. Doxycycline is Dorix, and it comes in tablets, 60 and 120 milligrams. Minocycline is Minocin. It comes capsules, oral suspension, and injectable, powder for reconstitution. There was a little picture of the oral. Tetracycline, like I said, it's a drug as well as a class. It's sumycin, and it comes in tablet form. The next group are the macrolides. Primary use is respiratory infections, bronchitis, pneumonia, that kind of thing. Also for STDs, specifically chlamydia. Side effects, a lot of patients complain it causes GI upset, nausea, vomiting, diarrhea. They don't like how this drug makes them feel. Although it's probably better absorbed on an empty stomach, we tell people, take it with a snack. Eat some toast or crackers when you take it to help stop the queasy that comes along with it. Now, I happen to be, most people when you talk to them, if they're allergic to an antibiotic, they're allergic to penicillins or sulfonamides. I'm allergic to macrolides. So when I told a doctor once, actually, you know, his MA or nurse or whoever was taking my history, and also at a pharmacy this happened, when they say, what are you allergic to? And I say, I'm allergic to macrolide. Does it upset your stomach? No, it closes off my windpipe. I'm allergic to macrolides. I'm so sensitive that one of the things when we looked in pharmacy practice last week, I was showing you Mary's mouthwash. One of the ingredients when we do Miracle mouthwash often is putting a macrolide, erythromycin, into that Miracle mouthwash. And one night I came into the hospital, and in our sink was all of the equipment from making Miracle mouthwash that nobody had washed and put away. So I'm like, so I went to clean out the sink. Just a drop of diluted erythromycin hit my skin, and I got a welt. Like, yeah, I'm not touching it anymore. Then, silly me, not thinking, I'm working at Ochsner a couple of years later. And if you do clinicals at Ochsner, or go to work at Ochsner, you're going to be very familiar with the red bins. The red bins are the return bins. So all the medicine that gets brought back from the floor usually gets dumped into a bin to be sorted later. So it was one of those shifts where we weren't all that busy. So there was a whole bunch of us at the conference table unpacking red bins and sorting them out. Well, I happened to be working in a bin that had come back from OBGYN. Erythromycin ointment is the most common thing that they put in babies' eyes after delivery. And I'm just touching the packaging. But guess what? Sometimes packages have residue. And I'm not thinking, and I'm just working. And I'm going like this, my neck's turning all red, and I'm scratching my hand, and I'm just and one of the girls is like, are you okay? And I'm like, and all of a sudden I stopped and I was like, maybe not. The pharmacist was like, take a Benadryl and go to the emergency room. And if I hadn't taken that Benadryl, I potentially could have gone into anaphylaxis. Because the doctor was like, it was really lucky that you took that Benadryl before you came down. So that sensitivity to these medications is very real. And it's progressive for patients. So the first exposure may be minor. The second exposure may be lethal. Or it could take many different exposures over time. I probably got exposed to macrolides maybe half a dozen times before it really started getting, like, I felt my throat starting to close. So everybody's going to be a little bit different. But if you're near something that you're allergic to, sometimes we cannot not handle it just because we don't have staff. So make sure you take precautions. Put on a pair of gloves. Put on a mask if you have to handle something that you're sensitive to. So just use my real life experience just to give you something to think about if you should have a sensitivity to something. So the GI upset is the most common, and that's why people are like, are you allergic? Yeah, I am. Now, azithromycin is Azithromax. It comes as a Z-Pack. Now, a Z-Pack is a pack of 6 250 milligram tablets. They take 2 on the first day, and then they take, I don't remember typing that. What am I looking at this morning? Do I have Azithromax in more than one place? Yeah, but this is not the slide it is. Then there was another, Zithromax is the other name. I guess now they call it Z-Max. I thought I had another piece on this slide. All right, we'll see if it shows up after. So the Z-Pak, it's a loading dose of two 250s, and then for 4 days they take more. And then we have Z-Max, which is the oral suspension. 1 dose, 1 gram or 2 grams, banana flavors for kids. Your macrolides will generally end in thromycin, and I'll talk about this. See, I am losing my mind. I am, but I'm not. This is a slide I remember this morning. Zithromax comes in tablets. The Z-Pak comes with the 6 250 milligrams, and then the Z-Max is the oral suspension, and it's cherry banana flavored. Erythromycin is what we call the prototype. It's the oldest one. The thing with erythromycin, this has the brand name of E-mycin, but erythromycin comes erythromycin base, erythromycin ethyl succinate, which the doctor would write EES. There's a whole bunch of different erythromycins. Just be aware of that. And erythromycin comes in a variety of different formulations, tablets, oral suspensions, ointments and gels, again, ophthalmic. And then there's this one. So this is a newer one. And they went and they messed up the drug stems. Why didn't they just make it thromycin? No, they had to mix it up and just put MICIN. Like gentamicin, like vancomycin, all the other ones that aren't macrolides. So you have to kind of remember this one is the special one. Fidaxomycin is difficid, and it's for Clostridium difficile. So the brand name is kind of telling us what bacteria it's for. It's a very highly contagious bacteria, very serious infections. And it comes as a tablet, 200 milligrams. Usually you'll hear people call it D-Cif, just for short, and difficid, D-Cif. Next are the sulfonamides. Like I said, some may not consider these antibiotics, just potent anti-infectives. Respiratory infections, urinary tract infections, very, very common to use. Part of the reasons people think these or call these anti-infectives is because they can also be used for non-bacterial infections, like protozoal infections. Commonly used to treat burns topically. They're used to treat ophthalmic infections. They're used, they have some anti-inflammatory components used for IBS and ulcerative colitis, and also used as ear drops for ear infections. Side effects, patients who have a sensitivity can develop a rash, nausea and vomiting. Sometimes taking the medicine causes a fever, which they refer to as a drug fever. Phototoxicity is probably one of the most common components. And there's also a risk for kidney damage. So the patient needs to drink lots of water while they're taking sulfonamides. They can cause what's called crystalluria. So if the patient doesn't have enough fluid, it's going to cause little crystals to form in the kidneys. And those little crystals can scratch and then create problems. Stevens-Johnson syndrome, pretty much all of your antibiotics can cause a Stevens-Johnson syndrome. It's an autoimmune reaction to medications. And what happens with that is it causes all of the epithelial cells to start to slough off. So patients like shed their epithelial cells. And that's both internal and external. And it potentially can be fatal. It does. They treat it like a burn. So if somebody's got Stevens-Johnson, they go into a burn unit because they're losing their top layers. Very painful. So like I said, we still have to drink lots of water and use sunscreen, but they need to avoid sunscreen with PABA. I can't remember. Butyric acid, poly something, blah, 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 blah. It's this really long word. But you can see it'll say PABA free on the PABA interferes with the sulfonamide. Now, sulfa drugs, we call them sulfa drugs. They have sulfa in the drug name, mostly. Sulfamethoxazole with trimethoprim. Now, trimethoprim technically is still a sulfonamide, even though it doesn't sound anything like it. So this is a combination drug. It's often abbreviated SMZ-TMP. It comes tablet. It comes single strength, SS, 400 milligrams per 80 milligrams. 400 milligrams of the sulfamethoxazole and 80 milligrams of trimethoprim. And it comes DS, which stands for double strength. So the doctor doesn't put the strength down. They just write SS or DS. So double strength is double the single strength. It also, the brand names include Bactrim. Bactrim also comes injectable. That's 80 milligrams and 16 milligrams per milliliter. Cotrim, only oral, and Septra, only oral. So those are the main groups. Penicillin, cephalosporins, quinolones, aminoglycosides, bactericidal. Tetracyclines, macrolides, sulfonamides, bacteriostatic. Then we have these others. So these either come in small groups or miscellaneous. Like I said, you don't need to remember this is a glycopeptide. You can remember it as miscellaneous. Vancomycin. It's got similar side effects to your aminoglycosides, so it's nephrotoxic and ototoxic. One of the brand names is Vancomycin or vancomycin. It comes as a capsule. And then there's a new one called Furvank, and that's an oral solution. And that's not on your drug list, but it's just a reference. Now, we also do vancomycin IVs. I made a gazillion of these as an IV tech. It comes in vials for reconstitution, and it comes pre-mixed, frozen. MRSA is one of the indications. Vancomycin is very, very potent, so we want it for those serious infections. So MRSA is methicillin-resistant Staph aureus. So methicillin is a penicillinase-resistant penicillin, but bacteria become resistant. If we don't treat infections, it can cause damage to our organs, and we can go to vanco. Unfortunately, we have MRSA, which is vancomycin-resistant Staph aureus. So we have drugs that are resistant to vanco as well. Now, this drug is an antimicrobial anti-infective. It's going to work on bacteria, but it's going to work on protozoas as well. This is classified as a nitromidazole. The drug is metronidazole, again, miscellaneous or just the anti-infective is fine. It's known as Flagyl. So Flagyl, like I said, it works against infection. We use it for acne topically. Antiprotozoal, if you have amoebic dysentery, diarrhea caused by microbes in your GI system, this could be effective. It's for systemic infections. This drug reacts, we use it for ulcers as well. It reacts with alcohol. So if this drug is ingested and there's alcohol, it causes you to become very ill very quickly. It's called a disulfiram-like effect. So the drug disulfiram is sold by the brand name Antabuse, and it's used for people who have addiction to alcohol. It causes what we like a negative reinforcement. It makes them nauseous, it gives them hot flashes, gives them a violent headache. And it doesn't take much alcohol for that reaction to occur. If you have a patient who's on metronidazole, it's really important they're aware of that. Not because they may have a cocktail or a beer, but there's food products and household products that potentially contain alcohol, like mouthwash that they might swallow a little, or salad dressings, or flavorings or colorants in certain foods that have alcohol in them. And it could make them really sick and they might not know why. It's so weird that even the IV label says don't have alcohol. Don't ingest alcohol. It comes in a 250 milligram tablet and it comes pre-made. Oh, the extended release 750 and pre-mixed, 500 per 100 ml. Now, the other thing about the IVs, these cannot go in the refrigerator. These are at room temperature. They come in at room temperature, they stay at room temperature. The lincosamines, this is clindamycin, again a miscellaneous, known as Cleocin. Comes capsules, injectable, topical, in solution lotion or gel. Topical, used primarily for acne. Clindamycin can be used for systemic infections or to treat acne. Then we have the zolidinodinones or the lindanones. It's linezolid, Zyvox. So in 2000, this drug came out. This was the first brand new class of antibiotic developed in 35 years. That's pretty cool. 2035? 40 years. No, 35. I was right. Capsule, oral suspension, the injectable. We use that in the hospital for very, very, very serious infections. This is if they have MRSA. Like, we keep going through other things, but it's also used for other types of sepsis. So, if you have a blood infection. And that's what it looks like pre-made. Comes in an oral suspension. Pre-mix, so it's not a reconstitution. And the capsules. So, vancomycin-resistant enterococci, vancomycin-resistant staphylococcus, or Staph aureus, MRSA, MRE. So those are your main systemics. Then we have some topicals. Who's ever burned themselves, had a scratch, right? Maybe got infected, might use a topical like Neosporin. It's a combination of neomycin, polymyxin B, and bacitracin. You're allergic to this? Well, bacitracin is technically I want to say it's an aminoglycoside. Triple antibiotic ointment is another brand name for it. Cuts, scrapes, burns. Neomycin, polymyxin B with hydrocortisone. So we've got anti-infective with a steroid. So steroids are used to treat what? Inflammation. So this is for ear infections. Pediaotic. And they're going to have their little, don't forget to put on your bottles. This is for the ear. We don't want somebody making the mistake and putting it in their eye. All right. Who knew tuberculosis was caused by a bacteria? Monobacterium tuberculi. So tubercular drugs are antibiotics. Now the weird thing is some of them can be used to treat certain lung infections caused by fungus. Rifampin is called Rifidin. It comes in capsules. Isoniazid, it's known as INH, which can be confusing because INH also is an abbreviation for inhalation, right? Can be confusing. We try not to use that abbreviation for isoniazid. It's so old it doesn't have a brand name. It's sold by its generic. Pyranzamide is PZA, comes oral, and S-ambutal is myambutal, and it also comes as tablets. So there's 4 agents used for tuberculosis, and guess what? They're all on the top 200 list. Ooh. About 20 years ago, we thought we were eradicating tuberculosis. We thought we had pretty much knocked it out. But people didn't follow their course of treatment, and we have resistant strains of tuberculosis. Tuberculosis is very common in certain populations, demographics. Homeless. It's spread through cough. If somebody coughs and puts the tuberculosis into the air, you could walk through an hour or 2 later and breathe that in. It falls at like 1 to 2 inches an hour. Yeah. So you had to have a TB test before you came to program. Now, some people react to that TB test but don't have tuberculosis. It means they've been exposed to it and built up antibodies, because it's a tuberculosis antibody test. So your body is reacting to the antibodies. That's what the Manitow test is. And then you got to have chest X-rays or a blood test, because they can't really rule you out through the TB test. They have to do. So then if you have to have a chest X-ray, you can't do that every year necessarily, so you get kind of a little waiver. Because the rest of us, if you work in a hospital especially, you get tested every year for TB. Because potentially you have a risk of exposure. You're dealing with patients that are sick. I know there's been several instances where I've worked in the hospital and you get a patient in and they've been there for a couple of days, and then all of a sudden there's like stickers on their door, or magnets, they use magnets, that says TB precaution. So when you go into the room, you have to wear a special mask, a special type of respirator. And if you go into that room, it has to fit properly. So you have to be fitted for these TB respirators. They could never find one that fit for me. So if I had ever gotten called on a code for a patient who has TB, I could not go in that room because I didn't have a properly fitting respirator. The small was too small, the medium was too big. Because we don't want it sneaking in through the cracks, kind of thing. So like I was saying, homeless population, other countries where there's higher incidence of TB, prison populations, and then patients who have HIV are very susceptible to TB. So the next group are a specialized group, urinaries. Urinary anti-infective and analgesics. So urinary tract infections definitely can be uncomfortable. They itch, they burn. They can become more serious. We can get what's called a retrograde infection. If the lower urinary system and it gets into your bladder, that urine kind of can go back up through the tubes, and then it can cause a kidney infection. If we think of my water bottle kind of as your bladder, when you lay down, the tube that leads back to your kidneys, the fluid can kind of go back a little bit up into the tube, and then it could spread the infection. That's called a retrograde infection. Nitrofurantoin, which I always thought was a cool word. I don't know. I just like the word nitrofurantoin. Is one of the urinary anti-infectives. It's known as macrobid. Comes as a capsule, and macrodantin, which is a macrocrystal capsule. So it's the inside component. Furadantin is just another name. Again, it's not on your list, but it's the oral suspension formulation. Phenazopyridine, which is another cool word, is pyridium. So pyro means fever, but in this case it's more like irritation. So phenazopyridine isn't a true anti-infective, but it's an analgesic. It kind of calms that inflammation and that pain that goes with that UTI. Comes as tablets. Oops. Oh, I thought I had a picture. You need to know a few things about this. It can turn your urine red or orange. We want the patient to know that it's the medicine, not the infection causing them to bleed that's causing their urine to be red or orange. Because some people with a urinary tract infection have bleeding as well. Because it's all abraded, just like your skin. If you roughed up your skin, you'd bleed, right? If the inside of your urinary tract is roughed up, it could bleed. This drug will excrete through body fluids. So if a patient wears soft contacts, it can absorb into the contact and discolor the contact. So patients who wear soft contacts, they can't wear them while they're taking this medicine. It can also come out in your sweat. So it could stain clothing. So don't wear a white t-shirt. It may turn kind of pinkish. And it takes more than 2 days worth of dosing for that to occur. So if the patient's taking it for longer than 2 days, make sure they know all that. I don't know that. I'd have to research. So those are the antibiotics, anti-infectives. I'm going to just let this start uploading, and then I'll go on to the antivirals.